Hello everyone, welcome back. So, it is not uncommon to treat childbearing age patients in the field of rheumatology. And as such, the question of birth control may come up from time to time. So that's the topic we're going to cover today. A good birth control method does two things. Number one, it will help you not get pregnant. Number two, it is safe to use. In terms of efficacy, all contraceptives can be divided into three categories. Number one, highly effective with a failure rate less than 1% per year. Number two, effective, meaning failure rate of 3 to 8%. And number three, less effective with 18 to 28% failure rate. That seems awfully high, and I'm probably dating myself here with a friend's reference, but this totally reminds me of when Ross got furious at the condom company because Rachel ended up getting pregnant despite them using a condom. Anyhow, along with condoms, diaphragm, spermicide, or utilizing timing of menstrual cycles are all considered less effective methods of birth control. But one thing you need to educate your patients on is that condoms, despite the high failure rate, they're the only form of birth control to prevent STDs, and that spermicide need to be used with condoms or diaphragm to improve efficacy. All these less effective methods are safe in all women with rheumatic and musculoskeletal diseases. So, then what are the highly effective contraceptives? Copper IUDs, progestin IUDs, and progestin implants are the three examples. And IUDs are considered safe in all women with rheumatic and musculoskeletal diseases. And progestin implants have limited data but are noted to be likely safe in all women with RMD. So what medications are in between? Not that you guys have to know all these different examples, but I'll just tell you anyhow. There's 5. Number 1, daily progestin-only pills. Number 2, DMPA or dipomedroxyprogesterone. Number 3, daily combined estrogen and progesterone pill. Number 4, weekly transdermal patches. And number 5, vaginal rings. And out of these, progestin-only pills is the only method deemed safe in all women with rheumatic and musculoskeletal diseases. Depo is not safe for patients with antiphospholipid antibodies or patients who are at high risk for osteoporosis. I'll cover this in a couple of minutes. The rest are not safe if they have antiphospholipid antibodies or if they have SLE. So, what did you learn from the last 3 minutes of what I just said? I think the important thing is that birth control needs to be safe and effective, and so far IUDs seem to be the best options that fit both criteria for our patients. And although condoms are a less effective birth control method, it's the only form to stop transmission of STDs. But guys, let's be honest, we're not OB-GYNs, and the chances are we're not going to be writing up the prescription for birth control methods, right? So what I'm going to cover in the next couple more minutes is what you really need to focus on. So there are 4 questions you don't want to miss, and they are: number 1, does the patient have SLE? Number 2, does the patient have APL antibodies? Number 3, does the patient have osteoporosis? And number 4, is the patient on certain immunosuppressive medications? Specifically, is the patient on mycophenolate medication? Okay, number 1, SLE patients. According to ACR's guideline, SLE patients whose disease is well controlled are strongly recommended to use effective contraceptives like hormonal contraceptives or IUDs over less effective options or no contraception at all. There is a conditional recommendation for use of highly effective IUDs or subdermal progestin implants because they have the lowest failure rates. SLE patients whose disease is not well controlled, they're strongly recommended to use progestin only or IUD contraceptives over combined estrogen and progestin contraception because estrogen-containing contraceptives haven't been studied in SLE patients with moderate or severe disease activity. There's a conditional recommendation against using transdermal estrogen progestin patch as well. Okay, number 2, patients who have positive antiphospholipid antibodies. See how I didn't say antiphospholipid syndrome? So whether they had clinical manifestations or not is a moot point. If a patient has presence of APL antibodies, it is a contraindication to use estrogen-containing contraceptives due to the potential risk of thrombosis. Also, DMPA should be avoided for these patients due to concerns regarding thrombogenicity because when they looked at a non-rheumatic patients, there was a higher VT risk associated with using dipomedrol shots. Guideline could not comment on the new progestin implants due to lack of data, but there's a strong recommendation for IUDs for these patients, or if not IUDs, the progestin-only pills. Just remember, copper IUD can increase menstrual bleeding and cramping for several months after insertion. For positive APL antibody patients, also there's strong recommendations against combined estrogen-progestin contraceptives because positive APL patients have higher risk of clot formation, and so does estrogen. So you may wonder, okay, estrogen is bad for blood clots, so is progestin not bad for blood clots? Well, the thrombosis risk for progestin-only contraception is still debated. However, progestin-only methods are widely accepted as a lower risk option if patients can't use estrogens but still need effective contraception. The specific progestin and its serum level affects thrombosis risk, by the way, and very limited data on non-RMD patients suggest that dipomedrol imparts a higher VT risk than other progestin-only contraceptives. The reason why DMPA should be avoided if patient has positive APL antibodies. DMPA not only increases the risk of blood clots, but it can also lower bone mineral density, which brings us to the third clinical factor. Number 3, people at risk of osteoporosis. Our patients in rheumatology office may be at risk due to glucocorticoid use or underlying disease. So ACR conditionally recommended against using DMPA for these patients because data suggested that bone mineral density declines by up to 7.5% over 2 years of use in a healthy population. Okay, number 4. Lastly, let's talk about topics of immunosuppression. Use of immunosuppressive therapy alone does not preclude use of any contraceptive method, but there's concerns that mycophenolate containing meds may interfere with hormonal contraceptives. So if someone is on Cellcept, there's a conditional recommendation that women take IUD alone or 2 other methods of contraception together. The mechanism behind this is that mycophenolate will lower serum estrogen and progesterone levels, and this in turn will reduce the efficacy of PO contraceptives. So you may ask which IUD then. Unfortunately, the mycophenolate risk evaluation and mitigation strategy program did not specify copper versus progestin. Okay, let me summarize what we learned today. When discussing birth control for rheumatic and musculoskeletal patients, the efficacy and safety of each birth control method plays an important role. But for us rheumatologists, remember the following 4 clinical factors that are very important. Number 1, does the patient have SLE? Number 2, did the patient have positive antiphospholipid antibodies? Number 3, is your patient at risk for osteoporosis? Number 4, are they on mycophenolate? So to summarize, SLE patients need contraceptives that work, but be wary of estrogen-containing contraceptives. For patients with antiphospholipid antibodies that tested positive, even without a clinical clotting event, avoid dipomedrol injections and estrogen. If someone had positive antiphospholipid antibodies, IUDs or progestin pills are the best. For patients who are at risk for osteoporosis, avoid using dipomedrol shots as well. Lastly, if someone is on Cellcept, it may interfere with PO contraceptives, so they are better off being on IUD or 2 other methods of birth control. So next time you're asked about birth control in rheumatology office, don't be flustered. Think about what you learned today and see if you can apply some of the tips here. Thanks guys for watching, and I'll see you next time. Bye-bye.